Hello and Happy New Year! Oncologists are asked to be many things in the course of their work, and in this EJC News Focus I've asked a handful to become clairvoyant. What do they think will be the big news in their respective fields in the coming year? New drugs, perhaps new approaches to treatment, accompanied as ever with new dilemmas. But overall there's a sense of a real possibility for better outcomes for patients.
I guess, like everybody else, we're waiting for new drugs that are targeted to different parts of the lung cancer. And I think maybe that's what we'll see in 2013 will be this major aggressive approach in lung cancer to rebiopsy. Now, for most tumours, it's not considered that, but in lung cancer, it really will be quite revolutionary because it will mean that every time we want to change a patient's treatments, which will be 2 and 3 times perhaps, we will want either another bronchoscopy, that's a light anesthetic, we will want a CT-guided biopsy, that is a procedure with a toxicity demanding services of another group of investigators like the radiologist. And it will be a much bigger, complicated process. And I think lung cancer patients have always been protected from anything too invasive or aggressive. And I think we will change our attitude and we will become aggressively biopsying lungs, livers, etc., so that we can give our patients the right treatment. And that, I think, will influence all of the new treatments, and it will be more major in lung than in other tumours. Breast cancer won't be such a big deal, bowel cancer the same, but lung cancer, it really will make quite a big difference to people's practice, but also the information we get and the treatment we can offer them will, for up to, say, 40% of our patients, will be quite different because of it.
Melanoma research has undergone this enormous change in the last 10 years. Since Mike Stratton and his colleagues discovered that BRAF was mutated in melanoma, there have been an enormous number of changes. And we've gone from a situation where already there had been no advance in melanoma therapy to a point where last year we had 2 new drugs licensed for use in melanoma. Now, almost certainly there will be additional drugs coming through this year which target the MAP kinase pathway. And of course we've got the new immunotherapies which are coming through. So for me it will almost certainly be new improvements in therapeutic approaches for melanoma patients. There'll be questions about the best combinations of drugs to give. There'll be questions about the scheduling of those drugs. And so I think there's going to be an enormous advance in the clinical translational research of melanoma research. But that's not to say that we won't continue to make, I think, very important basic research breakthroughs which will inform those clinical decisions that people are having to take who have to manage this disease. I think it's going to be a very interesting year.
2013 will be an exciting year for neuro-oncology. There is a number of phase 3 trials which are going to be presented. We are struggling about the right role and right positioning of bevacizumab in glioblastoma, and there are 2 phase 3 trials which will come out looking at radiation plus temozolomide plus minus bevacizumab in newly diagnosed glioblastoma. So this will be very important results, and we hopefully have some by ASCO, I would think, or by ECHO next year. Another phase 3 trial is an EORTC trial on low-grade glioma, which the data is maturing and should probably come out looking at the grade 2 astrocytoma needing treatment and comparing primary radiation versus primary chemotherapy with temozolomide. Progression-free survival is the primary endpoint, and we should have by the end of this year enough events so we can look at the data. So these are 2 areas of big importance. And lastly, there is a trial which took forward molecular testing in glioblastoma and looked only at the MGMT methylated ones and looking at the novel integrin inhibitor silengitide, and also in upfront setting silengitide plus temozolomide RT in MGMT methylated glioblastoma, and here again a phase 3 trial where everybody is waiting desperately on seeing some of the first survival results.
Could you predict what the big news in renal cell carcinoma will be in 2013?
I think in 2013 there will be much more data on how to select first-line treatment for the patient with favorable or intermediate risk, because so far we have 3 options: sunitinib, bevacizumab, interferon and pazopanib, and this is the first head-to-head trial, a COMPASS trial, a non-inferiority trial that will compare sunitinib to pazopanib. And I think that people might get more confident in using this new compound, which has been approved already years ago, but it has been compared to placebo in the first trial, so the data were, let's say, not as robust as they would be if we had a proof of non-inferiority.
I think the area of breast cancer treatment where we're seeing the biggest potential for change in the next year is the information coming out on the various new trials looking at the treatment of metastatic HER2-positive breast cancer. Within the last year, we've seen data from Cleopatra that adding pertuzumab into the combination of chemotherapy and Herceptin improves survival. We've seen data that TDM1 is improving progression-free survival. I think most people expect to see evidence of a significant improvement in overall survival. And therefore, by next year, I think there's a good chance that we may have 2 new drugs approved for the treatment of patients with HER2-positive metastatic breast cancer. The question is, I suppose, firstly, when will they be approved? But more importantly, are these drugs going to be affordable? In the current economic crisis, particularly in Europe, are patients going to be able to benefit from these drugs given the growing healthcare costs? We all hope so, but I suspect the news will be both clinical in terms of improved outcomes, but also some political challenges as well.
Are you seeing much better outcomes as a result?
Absolutely. It's quite phenomenal. Quite phenomenal. Patients on targeted treatment, back at work, looking after their families, coming every few months for a scan or a visit on oral therapies. Really quite phenomenal. Small numbers, but those small numbers really mark, you know, people who've been in lung cancer for many years. This is really quite a different treatment, and these patients have a totally different life now. Quality, I don't think our parameters would even assess it. I think to have someone back in their full-time employment, it's amazing with stage 4 lung cancer. Feeling normal, looking normal, functioning. So that's where the whole cost effectiveness is going to have to, is on a different scale. Much higher scale, agreed, but it's on a different scale.
While so much debate focuses on increasing costs, it's refreshing to hear of the step change that can be brought in some patients' lives by the new generation of therapies. How exactly to measure cost effectiveness is a debate that will run well beyond 2013. So with thanks to Mary O'Brien and all our interviewees, that's it for this month's EJC News Focus.